So we are going to present today on dialectical behavior therapy and its how it's different and similar to radically open dialectical behavior therapy.
Before we get going, we're just going to share accuracy, utility, and risks. So this presentation, it's going to discuss different clinical intervention principles from 2 different treatments based on the most recent research and clinical experience of myself and Jessica. And as with all clinical interventions, just be thoughtful about applying them, the skills and the strategies without appropriate training and supervision. And then neither of us are certified trainers in either modality. So this material and presentation can't be considered part of your training to become an official RO-DBT practitioner or a certified DBT clinician. And we have no conflicts of interest and no commercial support. Just 2 psychologists sharing some cool stuff.
And for our agenda, we're going to start with an introduction of the 2 of us, and then we will go into a background of both DBT and RO-DBT to give you a bit of the framework and theory behind it all. Then we will do a skills practice to get a little bit of extra ideas of how to apply the therapies. Then we'll go into similarities and differences between the 2. We'll complete the presentation with a case presentation so we can kind of bring in everything we've learned throughout the presentation and have questions at the end. Feel free to send questions throughout. We will jot them down and then we'll talk about them at the very end.
All right,
Take it away.
some quick introductions. I'm Dr. Katie Flanagan. I am a clinical psychologist and I'm the RO-DBT coordinator at UC-EBT. I am an official RO-DBT practitioner. I've received my level 3 training. At my core, I am a generalist. I serve on other teams at the center, including our traditional DBT team, but I've definitely been developing this specialty and interest in perfectionism and kind of rigidity, and that led me to RO-DBT, and my pronouns are she, her.
Great. And I'm Dr. Jessica Flynn. I'm a clinical psychologist. I'm also she, her. And I'm also a generalist. I do a lot of work in different areas, including with kids and adults, trauma, mood and anxiety. However, I really am passionate about DBT, and it takes up a large portion of my caseload. And I was trained in DBT through UCBT, actually, and worked there for 4 years on a team working with teens and adults. And then I started my own DBT program for adolescents in the Intermountain system, so at one of the hospitals. And then during COVID, I decided to move back home, which is Canada, Ontario, Canada. And so I'm back there and decided to start a DBT program with Sageview Health, which is a private practice in Mississauga, Ontario, Canada. And there we run a full program for adolescents and for young adults. I also have a private telehealth practice in Utah currently.
Beautiful.
Okay. So the primary goals here are to really help you better understand the basics of both of the therapies and to understand the similarities and differences so that you can develop confidence in identifying which therapy might be appropriate for your client, and then whether or not you are referring to a full program or what you're taking into account when you're looking at your own client base.
All right, so before we jump into the 2 treatments, I want to take a moment to acknowledge some of the shared history behind why these treatments were developed in the first place. So kind of why did we need new treatments like DBT when it was developed in RO-DBT? So both treatments were developed after noticing that a significant portion of individuals with certain personality styles, who also have like high comorbidities, high chronicity, they were just not improving in traditional therapy models. So for DBT, This was borderline personality disorder, but extends to a lot of other diagnoses that it's shown effectiveness for, that come from this underlying difficulty with self-control and emotion regulation, impulsivity, tolerating distress. And for RO-DBT, this is like obsessive-compulsive personality disorder, but similarly extends to other diagnoses that seem to come from this exerting too much control. Um, and we're going to dive more into these differences later. But really, this idea that when we are treating certain subsets of the population, personality matters. Actually, 10% of individuals in our community meet criteria for a personality disorder. But I do notice that a lot of the times clinicians are hesitant to diagnose personality disorders or don't feel as comfortable diagnosing personality disorders, but they are a really core part of treatment that might be getting in the way. For me, I was trained in graduate school and really had the benefit of learning DBT like early on in my training, which I'm really thankful for. And so I never struggled with that same like anxiety around treating individuals with a borderline personality disorder diagnosis. I actually really loved it. And I still do have a lot of fun with it. But what I was having a hard time, and maybe some of you can relate, is struggling with a certain portion of my caseload that really just was not responding to other forms of treatment, whether I would try cognitive behavioral therapy or acceptance and commitment therapy or traditional DBT. They were not seeing the treatment gains that they were hoping. And when I was consulting, kind of labeled this group as like almost like a depressive personality style that I couldn't adequately treat. And I really knew it wasn't them. Like all of those clients were trying extremely hard. And so I recognized like I just don't have exactly the tools that they need to help them. And so that's what really like set me off on this pursuit of finding that treatment and then falling into RODBT. So this theory of two overarching personality styles. So in the last 10 years, there's been some pretty remarkable consistency in separate large scale studies indicating the presence of these two overarching personality styles that tend to be precursors to the development of later mental health issues. And so one is described as under-controlled. So as children, and when you're thinking about people in your caseload and as you're deciding when you're kind of differentiating, I think it's important to kind of think about their early history. But as children, under-controlled individuals are often described as really highly excitable. They're overly expressive. They tend to be pretty conduct disordered or impulsive. So when they feel something inside, everybody knows about it. And they find it pretty hard to plan ahead or resist temptation. So if they see something and they want it, they'll just grab it and go for it. Um, and they just tend to do things how they feel according to the moment. And then there's this other style, which is over-controlled style. And so it's more cautious and reserved. As children, over-controlled individuals have been described as more shy or timid. They tend to really control or constrain their emotions, and they're able to delay gratification and tolerate distress for pretty long periods of time in order to achieve long-term goals. And they tend to not tell other people or make a big deal out of it. And they set very high personal standards and tend to work harder than most to prevent any future problems. But inwardly, they tend to feel pretty lonely, not part of their community, and kind of at a loss of how to join in. So we are going to do a little experiment all together. We're going to watch this video, and it's going to be of two children. And I want you to think in your mind from just learning about those two personality styles, which one would you label as more under controlled and which one would you label as more over controlled? And so this was the Stanford marshmallow experiment for those who don't immediately recognize this image. But it was a series of studies on delayed gratification in the late 1960s, early 1970s. And in these studies, a child is asked to sit alone in a room with one marshmallow. And they're told by the research assistant that they have to leave the room for about 15 minutes. And if you don't eat the marshmallow, then you get two. And so then they leave them in the room and they video record what happens. And so we're going to watch this. And again, just notice which one would I describe as more under controlled and which one would I describe as more over controlled. Okay. So again, taking a little quick note inwards, which one would you consider over controlled or under controlled? So I'll start with the first one, the little boy. We would describe him as more under controlled. So you could see that immediately after the research assistant leaves the room, he's sitting there and he kind of smells it, immediately picks it up, smells it, and then starts eating it. And you can see the expression of joy on his face. Like he's stoked. He's eating this marshmallow. And then takes a couple bites, and all of a sudden the marshmallow is gone. And then immediately you see this expression of guilt on his face. And then he kind of like goes to hide it because he knows, oh man, I just ate it and I could have had two. Right. And so you can see he's expressive, he's a little more impulsive. And then we see the little girl in the next one, and you can see that she's much more stoic than the little boy. You can't really tell exactly what she's feeling. She makes some slight expressions on her face, and then she slowly moves the marshmallow away from her, kind of like out of sight, out of mind, so I can like sit there and hold on and control myself. And we would describe her, yeah, as more over controlled. But I remember learning about this experiment when I was either in high school or early college psychology classes. And I remember being like told that the kids that could delay gratification had better long-term outcomes, like were more successful. And I remember taking that to heart, like, okay, then that means like, you know, I just got to delay gratification and I'll be able to like get the things I want and be more successful. And we're going to talk about kind of is that ultimately true, and to what extent is that true?
Okay. Yeah. And so as Katie's explaining, it seems as control has been better studied, so self-control, it seems that there is an amount of there's an amount of self-control that's optimal, and then there's actually an amount of that can be considered over control, or having too much, having very high constraint. And then there is obviously the one that we saw in the video as well as under control, high disinhibition. And that psychological well-being seems to be much higher at that level of optimal control. And that the different therapies that we'll be going over today, so DBT operates more with clients who are struggling with under control, and RO-DBT is more focused on those who are dealing with troubles with over control. So another way to distinguish those needing DBT and RO-DBT is through attachment style. So attachment theory, I'm sure many of you are familiar, but in general, it just refers to how individuals characteristically relate to others in close relationships. So relationships with parents, but also as they get older with intimate partners, with your own children. It's thought to develop early in childhood in the caregiver-child relationship, and it seems to be critical in how in the ability to regulate affect and stress, control attention, understand how one thinks about oneself, and to develop a sense of self-agency. Attachment style is also thought to mold future relationships, those more intimate relationships, through what's called internal working models. And when you think about adult attachment, so Bartholomew and Horowitz, as well as Brennan and colleagues, they have identified styles of attachment in adulthood. And those 4 categories are thought to be secure, which is where there's an internalized relationship, previous internalized relationship with caregivers that results in feeling like relationships are reliable. I can adapt to different social contexts and maintain a balance of my self-regulation and interpersonal regulation of stress. And then there's the category of insecure. And so for that, there's, you can see there's these dimensions here of avoidance and anxiety. There's what's called preoccupied, anxious preoccupied. So it's high anxiety, low avoidance. And these individuals are seem to be hypersensitive to rejection and can show compulsive care and attention seeking to try to engage that attachment. And then on the more avoidant portion of the graphic, you can see avoidant dismissing avoidance. So these are individuals who are not very sensitive to social interactions. They tend to avoid them, and they tend to be quite socially isolated. And then there's also fearful avoidant, which is a person who tends to still avoid relationships, but does crave them and has quite a bit of anxiety about wanting closeness and support. There's an additional category which has been identified later on that's related to disorganized attachment in children, but it's called the unresolved category, where individuals are essentially unable to cope under stress and suffer pervasive emotion dysregulation. And attachment theory accounts for a lot of the aspects of personality disorders. So there has been some research to look at which attachment styles are more related to certain personality disorders. And it seems that those with BP struggling with borderline personality disorder seem to have either a preoccupied, anxious style or the unresolved. So either very anxious about and very engaged in trying to get closeness with other people, or having trouble even connecting at all and really having sort of continual dysregulated affect. And then when we think about the personality disorders that are more common or more the ones that we would treat with RO-DBT, those are obsessive-compulsive personality disorder and avoidant personality disorder. Those fit more into the categories of dismissing avoidant and fearful avoidance, so really struggling to engage with that attachment relationship. And so that's another way to kind of differentiate what we'll be looking at. So when we think about the therapies we'll be talking about today, DBT is focused more on that area of the graph, and RO-DBT more on the avoidance area. Okay. So now I'll start with an introduction to DBT to give you a bit of the background in that therapy. So dialectical behavior therapy was developed by Marsha Linehan. She saw a group of particularly women, but people who were not really being treated very well with the therapy models that were currently in use in the 80s. And then she developed this in the late 80s, early 90s. And she was finding that this group of women who had a lot of behavioral dysregulation, often diagnosed with borderline personality disorder, had often a lot of parasuicidal or suicidal behavior. And that group of people, she said, you know, they can be helped. I want to help them. I want to figure this out. So she started thinking, this is a story she's shared many times, where she said that she started with trying the modalities that were available to her, saying that, okay, if I try the more cognitive strategies, cognitive behavioral strategies, that might work. So she worked with this group of people, and reliably she got back the response of like, you just don't get it. You're trying to change what I'm doing. You're giving me coping strategies, but you don't get what's going on at all. Like, I need you to understand what's happening to me. So then she tried a different treatment modality, which was more of the Rogerian person-centered approach, with warmth and understanding. And again, reliably, she got negative feedback, right? Like, this is not what I need. You need to give me some ideas for change. Like, I need to fix this problem. And so she realized that there was really a need for kind of both of those strategies to be combined. And she went even deeper and looked into Zen Buddhism and incorporated a lot of different ideas to develop the framework for DBT, that really incorporates a lot of the things necessary to keep people safe. And you'll see that it's been rigorously studied now for more than 30 years and is now an empirically supported treatment for BPD, and in fact tends to reduce suicidal thinking and suicidal behavior quite a lot. And it's also been adapted for many other populations and treatment problems, which I'll review in a bit. So when considering RO-DBT as a contrasting therapy to DBT, with RO-DBT, the main problem addressed is over control, right? And with DBT, it's more seen as a therapy that for those who are struggling primarily with under control. And so self-control can be thought of, as we've discussed, as the ability to inhibit competing urges, impulses, behaviors. You can delay gratification, right, in order to pursue goals. And so, and it can be applied across all different areas of life. And in DBT, we see that these problems of under control are occurring in all of these different areas, right? Like in thinking, concentration, in emotion, in the like expressing emotion that's maybe inappropriate for a situation, regulating impulses, and engaging in goal-directed behavior. So Linehan has reported that those that people with borderline personality disorder who are treated in DBT, that's also often characterized by difficulty modulating affect, with these emotions and behaviors sort of out of control, having quickly changing emotions, and having reasoning overwhelmed, right, and often engaging in what we call mood-dependent behavior. And supporting this theory, Yen and colleagues have found that both affect intensity and affect control related to number of BPD traits. So when looking at a person and how many BPD traits they had, if they had more, they typically also had more affect intensity and more difficulty with affect control. So the base of the therapy is biosocial theory. So we come from this framework. Often people with DBT really need to hear this because there's so much stigma and so much that is really looking down on, there's so many things that look down on behavioral dysregulation. However, this theory kind of explains why it would happen, right? So I love flowers. So I love the flower analogy. So I'm going to use that one, but others have used cars, things like that. But if you think about flowers, there's some flowers that take a lot of care. They need a lot of very specific conditions to thrive. So a really typical one is an orchid that needs a lot of care, and it needs very specific conditions compared to other flowers that don't really need very much care at all, like a dandelion, for example, that can grow in between the crack, like in a crack in the sidewalk. And so when we think about a person coming into DBT, they're often a person who's very similar to an orchid. So just biologically, they have a lot of needs. They have a very high emotional sensitivity, a lot of meaning that they're going to be very sensitive to a range of emotional stimuli that somebody else might not be. Their emotions react very quickly, so they might go from 0 to 100 really quickly. And then it's actually really hard to come back down to lower than 100, right? Or like it's very easy for someone to get stuck up very high with their emotion, and it takes a long time for it to calm down. So those are people that just have this sort of biological difference. And similar to an orchid, that can be an absolutely beautiful thing, right? It can lead to so much passion, creativity. Often these people can be amazing, successful human beings when they're able to have the conditions they need. So the conditions that are needed, right, is a lot of, when growing up, is a lot of validation and support and care. And we often find that sometimes the environment is traumatic and there's neglect or abuse, right? And sometimes the environment is just finds it very difficult, like it's just not the right fit for an orchid. So it's maybe the parents are more like dandelions, right? So that they are less able to, they don't understand all the depths of emotion. Or maybe a parent or caregiver or somebody around them that's very important is also struggling with really intense emotion and doesn't know how to regulate it. So often what happens with these people who have this high intense impulsive sort of emotional biology, and then they're faced with an environment that may reject them, even simply telling them, why are you having that emotion over and over, right? Just constantly telling somebody that your experience is wrong or not okay. That often leads to just the inability to develop skills, right, in order to regulate that emotion. What's needed is an environment that can really validate and support the emotional response in order to then develop the skills needed. So the idea is that with DBT, we're providing that environment and allowing somebody to be able to develop the skills necessary to regulate emotion. Because often if that doesn't occur, then people can get really disconnected from their own internal experience. They don't know how to regulate. They don't know how to calm down. They can go from very inhibited emotion to extreme emotion, can look to others to have to calm them down, and really have unrealistic standards for themselves and others. So the goal with DBT, the full program of DBT, right? We're not just talking about DBT skills. We're talking about, and we'll explain the portions of the actual parts of the program later on. But the full program of therapy involve the first stage of it is really creating safety, stability, and the ability to regulate in these in ways that maintain safety and stability. So we're working always on decreasing, like number one, decreasing the risk for suicide and self-harm, because you can't do therapy with a dead person, right? And then we're working on behaviors that interfere with therapy. And that often occurs, right, when someone's very dysregulated, under control, they're struggling with all of these relationships. That's all going to come out in therapy. It often means that therapists are saying, I don't really have the tools to help you, or they get fired, and they get fired from a therapist, or the person themselves like leaves the therapy very angry with the care they've been given. So there's a lot of focus on things that might get in the way of that relationship and actually engaging with therapy. And then there's also a focus on gaining emotional and behavioral control, so reducing emotional behavioral dysregulation. And then we're always working in DBT to engage clients. So we're increasing commitment constantly. It's a process throughout the whole program, and then increasing skill use. And we'll review the specific skills a little bit later on. And so the goal, obviously, is to create this person's life worth living. We don't want to be, they don't want to be living. We want them to thrive, right? Just like an orchid, under just the right conditions, we want people to thrive, and this is how we get them there. So there's a huge evidence base for DBT. And so, okay. So we have, sorry, I just got a text for time. So we have a huge evidence base for DBT, and initially there were randomized controlled trials that showed the effectiveness of DBT for borderline personality disorder and for suicidal thinking within that, and suicidal behavior. And so this is just a list of those initial randomized control trials. There was also a more recent randomized control trial done to look at the same program of therapy, but it was allowing, actually comparing it to, instead of what was typically done, which was treatment as usual, it was comparing it to expert therapy. And that study also showed the same effectiveness of DBT. You can see, I've just put this link here for anyone who wants to go in. There's just a huge knowledge base there. And so you can go and research anything that you might be interested in if you follow that link. And then there's been lots of other randomized control trials for different conditions, and even more studies just on looking at the treatment and how it affects different conditions. And so now that there's been so much research at this point, we know that DBT is an evidence-based treatment for borderline personality disorder, and that it significantly decreases suicide attempts, non-suicidal self-injury, and then related issues, right? Depression, hopelessness, anger, substance dependence, impulsiveness. And it increases things that you'd want to see, like adjustment and positive self-esteem. And then it also is an evidence-based treatment for suicidal behaviors just on their own. So we've noticed that suicide attempts reduced by 50% when going through DBT. There are fewer ER visits. So if someone's thinking about the cost of this, right? The cost of going to the ER is a huge issue. Obviously, safety is greatly increased if there are fewer ER visits, and just fewer psychiatric hospitalizations for suicidality. And then we know that just the skills training in and of itself, like I said, that's just a portion of the program. But when looking at just skills training, it does seem to be more effective than waitlist and just standard group therapy, and can help with these kind of issues, right? Again, it looks like sort of under those issues of under control, except for depression and anxiety, which are more broad. And there have been various adaptations, a lot of work done with PTSD. Melanie Harnett has done a lot of work with that. And so there's a lot of research to show that that can be treated within DBT. And then, as you can see, I'm not going to list all of these because you can see them here and you can refer back later. But many of these issues are, again, they look very typical of that under control problem, right? And then there have been many studies that have looked at the mechanisms of change, and Reg and colleagues reviewed abstracts and looked at certain indicators of these mechanisms of change, and they found that that in general, it seemed that DBT was working by increasing emotion regulation and self-control, also increasing skill use, and of course, like pretty much any treatment, right? The alliance or investment in treatment was really important. One thing that's interesting is that in DBT, there's a huge focus on the alliance and the investment in treatment. And so it's really good to see that that's also one of the it seems to be an active ingredient. Raj and colleagues did suggest that much more research needs to be done in this area to really look at the mechanisms of DBT, but these are the ideas of how it's working right now. Okay. Over to you.
Thanks, Jessica. All right, now we're going to get into radically open dialectical behavioral therapy and a little bit of the background on that. So RO-DBT is informed by 30+ years of translational research development, and it's an evidence-based treatment for individuals who cope with their emotions by engaging in excessive self-control. And it's now recognized as an empirically supported treatment by the Society of Clinical Psychology, Division 12 of APA, which is awesome. And the treatment developer is this lovely guy right here with his like soft, warm smile, Thomas Lynch. So the problem of over-control, as we mentioned in the earlier, existing research kind of saw self-control as this linear construct, the more the better, right? Like my takeaway from learning about the marshmallow experiment was like, the better I can control myself, the more successful I'm going to be. And getting a doctorate is a measure of self-control for years and years. So but maybe now looking at the research and understanding a little more deeply, you can have too much of a good thing, right? And so there are individuals that are over controlled, that can't flexibly engage their ability to control. They're controlling everything in all contexts. So RO-DBT is also developed on a biosocial theory of over-control, similar to DBT. So in RO-DBT, we have 4 set pre-treatment sessions that I'll talk about a little bit later, and there are really specific scripts that we read. And one of them I'm going to, in part, read to you as I'm explaining the biosocial theory, because it's something that I introduce to all clients that I'm approaching RO-DBT with. So for the biosocial theory, just like we're all born with different eye colors, we're all born with different brains. And our brains influence how we perceive the world. And so if you imagine a person that's born with a brain that's more sensitive to negative things and less sensitive to positive things, when this person walks into a rose garden, we'll use flowers again, their brain notices the thorns over the flowers just immediately, right? Their brains also have an ability to have a high ability to control themselves, and they tend to really notice details. So they get locked into the details and they have trouble pulling back and seeing the whole picture. So this is this biological sensitivity part of the biosocial theory, and I'm going to go more in depth with it a little bit later, because it's a core part of how you assess if a person is effective, would be how would be treated by RODBT or not. So then I want you to imagine that same person with their brain in this specific way, growing up in a family, a culture, or a social environment that highly values self-control, performance, and not making mistakes, right? And so from different clients I've worked with, sometimes this is a family system that really highly values achievement at all costs. Sometimes this is a larger community. I grew up in the Silicon Valley. That was a pressure cooker, high intensity, achievement focused area. For other clients, it is growing up in the military, right? Mistakes are intolerable. Don't be vulnerable. Structure and control is essential. So it's very different for different people where this environment starts to interact with their natural biological predisposition. And so what might this person learn to do, right? With this sensitivity, with this environment that is like reinforcing it and interacting reciprocally with it. So first, this person might learn to avoid taking risks so they never make a mistake, right? Second, this person might learn to avoid showing any vulnerability, even when they're distressed, so they can avoid ever feeling or appearing out of control. They can mask their inner feelings and keep a poker face. They also might learn to be cautious when getting to know new people, and which leads like other people to experience them as more distant or aloof, right? So I'm going to go more into some of these deficits that are created from this kind of synergy of the biosocial. So there's 4 core deficits that we treat in over control, and these are the things you'd want to be assessing for in your clients to see if they would be an effective fit. And there are specific assessment measures that we'll talk about later. So one core deficit is a lack of receptivity and openness. So they tend to avoid feedback from their environment, whether that's through, a defensiveness or almost like a over accommodation of the feedback. One way in which they're not taking it in fully and incorporating it in an effective way. They also tend to avoid new situations, right? So just do the things that work. And a lot of learning is in feedback from other people and in experiencing new things. They also struggle with a lack of flexible responding. So they like structure and control, and they're rigid in how they respond, regardless of the context. Doesn't matter if it's work or at home or at a party or at the gym, it's the same response. They also struggle with emotional expression and awareness of what their emotions are. They naturally often struggle to feel emotions as intensely. That's not always the case, but they also have a history of suppressing their emotions for such a long period of time. It's hard to figure out what you feel when you're pushing it all down. And so this comes across, these individuals are often very stoic. So they're not giving you a lot of nonverbal signals in the room, or they're very disingenuous in their expressions. So they like are smiling at everything, whether it's like a happy or very distressing thing. They also lack social connectedness and intimacy. So they have this like aloof and more distant style of relating, which all creates really intense emotional loneliness. And that's at the core of what RODBT is treating, emotional loneliness. So this temperamental predisposition. So this is really, really important and something that the research focus a lot on, because it is impacting our perception and our ability to regulate ourselves at the sensory or pre-conscious level. So this is happening in milliseconds. And um, this is a really, really important thing to think about when you're interacting with these clients, is that it means that over-controlled clients can't talk their way out of their rigidity, right? Which is an assumption of other therapy models like cognitive behavioral therapy, where if you change your thinking, you can change how you're feeling and in your behaviors. These clients can't. This is the lens by which they see the world and perceive it constantly. And so even though you or I may moderately lean towards under control or over control, um, and I lean on the over controlled side, a lot of psychologists do. Um, but we still retain our ability to flexibly respond, right? So I have biotemperamental predispositions in certain ways, but not so high that I'm rigid in all settings. And these clients are rigid in all settings. So for an example, if an over-controlled individual walks into a party and they're seeing a group of people laughing together, they are biologically predispositioned to see the potential for harm in the situation than to see the potential reward, in a matter of milliseconds. So their defensive arousal rises. They have urges to flee that get triggered at this pre-conscious level. And so before they even know it, they've perceived it as a threat. Their brains made up their mind. And they quickly have a conscious thought that's like, I'm considered an outlier. I'm not good at telling jokes. I'm going to look stupid if I join them. And so by contrast, if somebody doesn't have so much biotemperamental predisposition, they're not perceiving it as so threatening. And they're like walking into the exact same party, exact same situation, and they're saying like, oh, look, it looks like they're having a good time. Like, I'll join them. Maybe I'm like a little self-conscious joining in with a group, and I don't know exactly what they're talking about, but it looks like fun, right? They're laughing. So this is this biotemperamental predisposition. All right. Um, So creating social safety, right? When we have this biotemperamental predisposition towards threat, what do we do about it? So RODBT actually teaches over-controlled clients skills for how to activate their social safety system and turn off this biotemperamental heightened defensive arousal. It'll always be part of you, right? Your brain is developed that way. But we can learn how to downregulate it. And when we're able to do that, it allows somebody to be more open, vulnerable, and connect with others. When we're threatened, we are rigid, we're not showing a lot of emotion. It's very difficult to engage naturally. And so RODBT also teaches therapists how to activate social safety in both themselves and their clients. So an important part that I'll continue to talk about along the way is not only are we teaching our clients, but we're doing really specific things in the room when you're doing RODBT to support the client in feeling safe. We arrange our rooms in a specific way. We make sure the temperature is not so hot. We are using open-handed gestures. We're modulating the tone of our voice. We're using facial expressions. We're not putting too much heat on them in moments where they need a little bit of space to regulate. And that is really kind of providing an environment where hopefully treatment is not so overwhelming. These are clients that tend to leave therapy pretty easily and abandon the relationship because it's pretty overwhelming. All right, so current evidence base. This is all straight from my training in Radically Open. It's all listed there. So I just wanted to make sure you guys all have access to it. Really, the transdiagnostic nature of RODBT has spurred new thinking and new research targeting like a really broad range of disorders and treatment settings. Extended to different age groups like adolescents, older adults, young adults, different disorders like anorexia, chronic depression, autism, over-controlled personality disorders, treatment-resistant anxiety, and also different cultures and countries. So Europe, North America, South America, Asia, and then also different settings like forensic inpatient and outpatient. And then even to a wide range of providers. So nurses, social workers, psychologists. In my level 3 training, I was actually there with a dietitian local to Salt Lake, Kayla Jessup. So she was there getting level 3 trained, which is amazing. And then also there's been development and application of different modalities. So like RO skills alone, multifamily training, RO couples therapy that are all continuing to be developed. So these are some of those trials that you can check out. And on children and mechanisms of change, and there's a link here for those research papers. All right, we are going to jump into the skills practice, starting with an RO-DBT skill. All right, so I'm going to be teaching the RO-DBT skill, the big 3+1. And so this is a skill to activate social safety and increase social connectedness, right? So I just went over how biologically temperamentally sensitive these clients are. And so they're often interpreting the world as unsafe. They're getting really easily overwhelmed. And so the good news is that we can learn some skills shown in research that can turn off that or minimize that defensive arousal by activating areas of the brain linked to social safety, which allows us to connect with those around us. And so there are 3+1. And the +1 is that you can only do it when you're sitting, so please don't do it when you're standing to activate our social safety. And these can work almost anytime and anywhere, regardless of how stressful the situation may feel. So first one, I'm going to kind of break it down and we're going to all practice it together and then we're going to link them all together. So first one is often when we're threatened, we're sitting up in a pretty like tense state. So if everybody, wherever you are, if you're sitting and you're able to kind of sit up in that more like tense, anxious posture. And when we're doing a +1, we're just leaning back in our chair in a more comfortable, chilled out position, like this beautiful, this guy here in this beautiful orange chair. So he's sitting back, he's relaxing. Maybe you're having a little bit more of like an open posture. Can lean back a little more. So I'll have everybody sit up again, kind of more tense. And then you're going to be just leaning back, and you'll have them do this in session. You'll be doing this in session when you notice that anxiety or the threat is high. Then for the next 3, you are taking a deep breath from your diaphragm, because that is really innervated by the muscles that activate social safety. So you want to see a lot of the movement of the breath being in your belly. So you take a deep breath, also kind of like a sigh of contentment, telling your mind, like, we're safe, it's okay. Then you're making a closed mouth smile. So this is a smile where the sides of your mouth are slightly upturned. You're not showing your teeth, but your lips are kind of tight across your mouth. So kind of like this. And then you also see those beautiful little crow's feet come out. Okay. And usually when you're making a soft smile like this, you're making eye contact with someone. And that activates social safety. And the reason we don't do it with our teeth, or teach clients to smile with their teeth, is if you've ever been in like a group picture, or someone's been trying to take your picture and they're taking a little bit long and they're kind of fumbling with it. You'll hear people, or even with yourself, you're like, oh, hurry, quick, take it. Otherwise, I'm gonna start to look weird. And there's truth behind that. We can't really hold a genuine teeth smile for very long. So if you're trying to do that to activate your social safety, it's gonna quickly look weird and not be giving you the benefit, or the person outside of you that feeling of safety. So we're doing a closed mouth smile. And then last, an eyebrow wag, which often this is where I see clients struggle the most with. They feel the most comfortable doing this, but this is where you, these 2 little hairy things above your eyes, you move them up and then down. So that's an eyebrow wag, so I'll show you. That's an eyebrow wag and then a soft smile. This is a universal sign of openness and warmth and connection. So whenever you see, like if you're at the airport and you see people greeting each other after a long time, they will be eyebrow wagging at each other, right? So if I'm seeing a friend, I'm going to be like, oh my gosh, it's so good to see you. I've missed you so much, right? My eyebrows are pretty high and they're kind of moving. Whereas if I was to say the same thing to someone, and I'm at the airport, but I'm not moving my eyebrows, I'd be like, oh my God, it's so good to see you, right? It's so much more muted, and even the tone of my voice starts to shift pretty quickly, indicating I'm not feeling so like open and wanting to connect. So taking a deep breath, we're doing the soft smile and the eyebrow wag. Okay. So we're going to combine it all together to finish out the skill. So I'm going to have everybody sit in like a tense position. And then we're going to lean back, get comfortable, take a deep breath, closed mouth smile, and eyebrow wag. And one more time, we have everybody sit up, kind of tense, lean back, soft smile, take a slow deep breath, eyebrow wag. Okay. And I want everyone to just notice what it feels like to do those actions. And this is something when I'm teaching it in skills class, I'll encourage them to just notice, what does it feel like when you do it? Did you notice anything different in your body? Which of the 4 actions did you find it easiest to do? Which one was most difficult? Try out that one that's most difficult until it becomes easier. So yeah, that's a big 3+1.
Thank you, Katie. We have picked skills that kind of go with one another and show how each therapy is kind of trying to engage clients in slightly different things, although of course there's some overlap. So with what Katie was doing, she was trying to get us to engage, especially in the social interaction. With DBT, much of our focus early on in treatment is trying to get somebody to not necessarily disengage, but regulate. So maybe disengage first and then kind of calm the body down enough to then be able to engage effectively with the environment. So if this was a social situation, for example, you would be trying to say maybe getting away for a second and then using one of these four that I'm going to review for you. And this, because these are these are just in the category of distress tolerance skills. So they're allowing us to tolerate distress so that we don't engage in crisis behavior. Okay. And so this is a tip skill. A lot of people might have heard of it. So I'll just go through each of them. And then I similarly to what Katie was asking you, I'd love you to just check in with what your body feels. And for this skill, kind of pick which one you think you need today. And we're only going to do one. So I'll explain the four and then I'll get you to pick one and do it just for about a minute. Okay. And so the first one, temperature, is we're trying to calm down. Again, we're trying to just get through the difficult moment. And this one is where we grab ice, like you can use the best way to do this, or the most effective way to do this, is to get a bowl of ice and just put mostly cold water in it and a few pieces of ice. And then you're going to dip your head in it and hold it there for 30 seconds, or you can hold it 10 seconds, take it out, another 10 seconds, take it out, another 10 seconds, okay? And if you don't have ice, and this is what we say to clients as well, if you don't have a bowl of ice water available, then you can use ice packs. And if you use ice packs or just ice in a bag or something cold, like a really cold drink, you can put it on you just want to put it on your cheekbones or on your forehead so that it actually does what this skill is supposed to do. So what this skill does is it activates what's called the dive reflex. So for those who are scuba divers, I am not, but I have just been told about this effect. If you dive really deep, your body will naturally, and it senses the cold and it will naturally kick in your parasympathetic nervous system, which is the rest and digest, the calm down nervous system. And so we're essentially doing like little hacks to try to get your biology to navigate this really difficult emotional moment. Okay, so this one I absolutely love. Some people absolutely hate it. So just you could give this one a try if it feels right for today. And the I is for intense exercise. This one is navigating that difficult moment by getting out like a lot of energy and getting your body moving. So Marshall Linehan suggests that you could do exercise for 20 minutes. And most of my clients, when I'm working with them, that seems like a little bit much when you're in a really intense moment. So I'm not saying don't do what Marcia says. You should probably do what she says. But also you can try things like what we often do are like really intense movements. So like jumping jacks or push-ups or sit-ups, whatever feels right, mountain climbers, to really get that body activated, right? And again, we're trying in that really difficult moment. So the body is really already activated. We're just trying to get sort of the energy out in a way that's more effective. And so you can just do that in your chair. You can get up and do jumping jacks, or like I said, push-ups or sit-ups, or run on the spot. And you're just doing it until you feel you've kind of navigated that really difficult moment. And then paced breathing is one that's really great to use anywhere, right? Because people can't really see you breathing unless you're like really breathing. And when you're really distressed, you might be breathing like that, right? You might be breathing that sort of very anxious chest type breathing. So this breathing is where you're breathing in and then breathing out double as long, like twice as long. So most people are breathing in about a 4-second count. So you breathe in for about 4 and you would breathe out for, 6 to 8. I tell people when they're starting this, when they're in that crisis moment, they're often doing that anxious breathing is often a longer in breath. So we just try to slowly work toward getting that longer out breath. So you do like a breath in and then just try to breathe out through your mouth, breathe in through your nose, and then try to get that breath, the out breath longer. If you're probably relatively calm, I'm hoping anyway, watching this presentation. So you know, if you're already relatively calm, you can probably do a 4-second in and 8-second out. And then paired muscle relaxation is another one that is useful kind of anywhere. And so what you can do for this one, it's where we tense and release, or tense and relax different parts of your body. You can do this really quickly by doing big parts, like taking sort of your head and shoulders and tensing that and releasing it, and then your whole your chest and abdomen, tensing it and releasing and going that way. Or you can do it much longer by going, you know, sort of muscle by muscle from the top of your head to your toes. Okay. So for today, because we're doing we're doing about a 1-minute exercise, just do the bigger areas. So what you would be doing is just really tensing every muscle in your head and neck area and shoulders, and then releasing. Okay, so you can do like a 5-second count, tense, and then release for 5 to 10 seconds. And then you would do that with your chest and just tighten everything, your shoulders, your chest, your abdomen, everything you possibly can. You can do even longer, 10 seconds tense, and then 10 seconds release. Okay. And so I'm going to just put a timer on for us, and for 1 minute. And so I'd like you to just take a moment to check in with your body and see what would be really helpful for you right now to do for your body. And again, you kind of envision yourself or a client being in this place where it's very intense for you, and maybe pick one that you want to practice, or pick one that feels right for right now. And then I will set the timer for 1 minute, and I'll get you to practice it. So go ahead and start now. Okay, and we're done. So just come back to the presentation when you feel ready, your body feels regulated enough. And I think we were gonna just address the chat a little bit. So we're gonna do, or we're gonna come to that at the very end. Questions that are in the chat.
I think we might come back to it. I tried to answer some of them.
Oh, in the chat. Perfect. Okay. And we will review them more with everybody, because there's some great ideas and questions in there.
Mm-hmm. All right, so we are going to go into the similarities between the two treatments. So we're going to talk about how treatment components are similar in both, behavioral principles, dialectical philosophy, and client presentation.
Okay, so for treatment components, both treatments have a pre-treatment period where there's an orientation to the treatment, and the goal is to orient and commit to the treatment. So understanding what it is, what you need to do, and then individual sessions start for both treatments. And within that, at that time, there's also group skills training, meaning that someone's attending group to learn skills. And there's also in both treatments, phone coaching availability, meaning that you can reach out to your therapist by phone, and consultation team, where the therapists working together with the same clients are meeting to discuss the therapy.
All right. And then principles of behaviorism are used in both therapies to understand and really modify behaviors, right? So at the core, these are both behavioral therapies and interventions. And we're targeting those in a lot of different ways. So all these strategies here are listed to really identify the problem behavior, specific things, targets that are getting in the way of their life worth living or life worth sharing, and the antecedents to that and the consequences that may be inadvertently reinforcing them. So in both therapy models, a core part of treatment, individual sessions, are behavior chain analyses. We're just doing them on different problem behaviors, but that core behavioral principle of what are your, have a behavior chain analysis here for RO-DBT, but what are your contributing factors? What prompted it? What are the relevant links, like your feelings and thoughts and actions and sensations that led up to the problem behavior, the thing that we're really trying to work on? And for RO-DBT, this is social signaling. For DBT, this is like emotion regulation, distress tolerance, suicidal, self-harm, whatever that behavior is, and then the consequences. All shaping both of these interventions and something that we're thinking about throughout treatment. How do we shape this behavior into a more effective behavior?
And both therapies are rooted in dialectical philosophy. So for those who might not be familiar, I had no idea what this was before starting, but it's just this idea of that opposite, that actually in order to change and come to any kind of decision or conclusion in life, that we need to kind of incorporate opposite ideas. So this is it originated with the philosopher saying that if there's a thesis, like a first idea, somebody presents one idea, then there's an antithesis or antithesis, and that is the opposite idea. So a reaction to the original idea. And then in acknowledging both of those, you can come to a synthesis. So let's say I did want to do this presentation today, but let's say I didn't, and I was nervous or something. So I was saying, I'm really nervous to do this presentation. I don't want to do it. And then Katie was like, no, it's really important and you're going to do fine. And then I was like, okay, well, maybe we could do it together, right? So, or whatever that was. So you always want to work with these opposites. And instead of using the idea that you just sort of, one of them wins, like one idea is better than another, you're always kind of doing what's called a dance in DBT and RO-DBT, like a dance between these different ideas, and finding a synthesis there. So in session, you're always trying to actually engage in a dance between two opposite ideas. And we're going to go into what that looks like in each therapy when we go through the differences section.
And so there are some similarities in the client presentation for both individuals that are a good fit for DBT or RO-DBT. Both sets of clients show up as very treatment resistant, have likely tried other treatment modalities, and they have not been effective to the level that person really needs. They also, for both, have high rates of suicide and self-harm. And so this is pretty well documented for under-controlled, but it's also very, very true for over-controlled. There are just some differences in how it presents that we'll talk about later, but both people who would be a good fit for DBT or RO-DBT have high rates of suicide and self-harm acts. And then they both sets come in with really core skills deficits. So there are really areas of their life where they are not able to effectively engage that require kind of these more comprehensive treatments.
Okay, and now we'll be reviewing the differences. So we'll be looking at how the therapies are different in therapeutic stance, in the primary focus of therapy, in the skills focus, and then in client presentation.
All right, so for RO-DBT, the therapeutic stance, your aura, as a therapist in the room, is you are much less directive. These are perfectionistic, over-controlled, rigid, threat-sensitive individuals in the room, and if you come too hard at them and add too much structure, it's quickly rejected and experienced as overwhelming. So we're less directive. We're in this really together, and we're encouraging independence of action and opinion and self-discovery through a skill called self-inquiry. That's a really core part of RODBT. Um, and there's a word in RODBT that's called smuggling. We like smuggle ideas in, which means we kind of plant the seed, or we talk about part of the idea of a specific topic that we're hoping to work on, and you let the client kind of marinate on it and consider it for themselves. We really don't want to kind of go for it too quickly and too intensely, where it will be more easily rejected. Then we celebrate really vulnerable and unplanned expressions of emotion. That is a core deficit. So anytime you see it in the room, they're just expressing themselves more disinhibited. You are noticing it, praising it to the extent that they can handle praise or find it rewarding. And you're also supporting them in letting go of always trying harder. These are clients that they're always focused on trying harder in some way. And we want to help them learn how to slow down. And so that's often something I'll have to say in the sessions of, I know there's a lot of urge to figure this out and move through it and get it done quickly, but actually there's so much value in us slowing down and experiencing it, and talking through it. And some of the dialectical dance that I do, and that RODBT therapists do in the room, is this dialectical dilemma of non-moving centeredness versus acquiescent letting go, which is kind of this dialectical dilemma of when do I know whether to hold on to rather than let go of a case formulation that I have, a theoretical insight that I have, a personal conviction about the client. Um, how do I hold these both in order to model this like core RO principles to the client, maintain their engagement, rupture or repair in our relationship? Um, and it's basically informed by this idea that all of us come into the therapy room with regulatory and perceptual biases, and they influence me, and they influence my client. So I have to be able to handle, when do I hold strong to something that I believe, and when do I know when to let it go? And that can be a tough thing, that kind of balancing of healthy self-doubt. And then the other one we do is playful irreverence versus compassionate gravity. And this is a dialectical dilemma of how we engage with these really emotionally and socially isolated, over-controlled individuals, where we're really welcoming them back home to their community. RO therapists are considered tribal ambassadors. We are the people that are like, hey, we have missed you in our community and welcome back, and I want you to experience that. We also want to challenge them at the same time. They're here for therapy. They've got things to work on. And so this playful, irreverent side is the part of the dialectic. It's like the therapeutic cousin of a good tease, between friends, where you're like, I see you there. Like, you're not going to get away with that, right? But I'm not doing it in a way to punish you. I'm doing it in this lighthearted way to notice something that we need to change. And then on the other side, this compassionate gravity, where when in moments where your client is really showing up and pushing themselves and being vulnerable, you want to take that moment to slow down and signal that like gravity and importance, and social safety to them in those moments. So that's part of the dance that we're doing and how you show up in the room.
Yeah, and in DBT, the stance is much more directive. So we're often working on maintaining a really firm direction with clients while also incorporating flexibility and warmth. So that dialectical challenge is for DBT, it's acceptance and change. The main one is acceptance and change. Um, and so what that looks like is that much of this, so we're using a lot of acceptance type strategies, which are typically called reciprocal strategies, where there's a lot of validation, support, warmth, understanding that this person is where they're at for a reason, they're struggling, they're in unbearable circumstances, right? And then at the same time, using irreverent strategies, which Katie also mentioned, but these strategies that sort of shock you and get you out of what you're thinking, and they push you a little bit. And these strategies are meant to kind of then bring in the side of like, okay, well, you are where you are, and we need to change at the same time. And many of the assumptions that we bring into, well, all of the assumptions essentially we bring in to our therapy session as a therapist are rooted in that acceptance and change. So one of the main ones is somebody is doing, the client, as well as anybody, including the therapist, the client is doing the best they can, and they need to do better, try harder to change. And so, and it really is a dance in the session. So I'll spend, quite a bit of time really connecting, depending on what's appropriate in the moment, but really like hearing what the problem is, right? There's a huge argument or conflict or an issue that we're trying to address. And then I'm also using strategies of like, what are we going to do about that? Like I'm making it really like shocking and different and bringing in some change. And I know one of the therapists actually who used to work at UCBT used to like in the middle of something, bang the table, and it just would like shock everybody for a second and jolt everybody. And that's actually one of those tools that is used, not necessarily hitting the table, but like some kind of tool that a therapist can use to kind of shake up the intensity and stress of the moment. And so also therapists and DBT have a high level of daily involvement, meaning that it's not always daily, but often when somebody starts and they're really struggling with BPD and dysregulated behavior, or suicidal behavior, they will need frequent phone coaching. And phone coaching is really not just for crisis intervention. It's actually, that's one function of it, but it's actually more effective if used as skills generalization, meaning like we can teach, interact with somebody in a moment when they're struggling, and we can actually get an opportunity to validate, support, and teach skills. It can also be used as a way to maintain the relationship. Like I've had some clients who, I don't know where they're living, for example, and like I'm really concerned about them, or I'm really concerned about their suicidal behavior. And the only thing that really keeps us going is like the fact that we're able to, like I'm able to say something to them by text, like I care about you, I'm here for you, like I want to be there, right? And but with that comes burnout for the clinician, and they really have to be careful. So as a therapist, when you're working with these clients, you're required to be attending consultation team weekly, which is a difference from RO-DBT, where you don't need to do that. And so, but that's to really ensure that you're able to hold your own limits and stretch limits when you need to, right? Because we try to do both, and to reduce possible burnout from from dealing with this dysregulation within the relationship a lot. And so the consultation team is actually set up to help the therapist provide sort of therapy for the therapist as well as consultation. And so the therapist can really have a place to go and get support in order to deal with these difficult behaviors that are coming up. And overall, the therapist is really working on trying to celebrate willingness to control behavior or to be engaging behavior that's effective in the environment.
All right, so the primary focus of these two treatments and what's different about it So at the core, RO-DBT, we are treating emotional loneliness, right? If you put anybody, the worst thing we can do to someone, one of the worst things we can do to someone is put them in solitary confinement. Anyone in solitary confinement is going to be depressed and not enjoying life, right? And so at the core, we are really working to treat this emotional loneliness and bring them back into their community. We also have a treatment target hierarchy in therapy, similar to DBT, for how we focus our sessions, with similarly to DBT at the top being addressing any imminent life-threatening behaviors. In RO-DBT, life-threatening behaviors are usually planned, usually well-kept secrets. And we mostly intervene with them at the beginning when we are assessing thoroughly and making sure that there is it's not imminent. We have some space to work. And then if there's any dramatic increase in suicidal thoughts or in self-harm behaviors, then we will address those as the first thing in session. Below that is attending to the relationship. And so we talk about these as therapeutic alliance ruptures. They're really, really welcomed in RO-DBT. The idea is that if you're not having alliance ruptures or relationship ruptures with RO-DBT clients, your relationship is superficial, that they're not expressing themselves to the extent where you're being able to have those like kind of rifts in the relationship in order to then repair them and build into a stronger, more deeper relationship. So we focus on those, and these can be really subtle in the room, where all of a sudden your RO client I have one that just like will slowly start becoming more and more vague in their responses. And I know I've said something that's bothered them or didn't fit right. And that's their kind of signal to me that there's now a rupture, that they feel misunderstood. And so then that would be a moment where I drop everything else as long as safety is in place and I address that. And there's a specific protocol for addressing alliance ruptures in the room. And then below that, we're targeting the severe behavioral over control, this aloofness and distance, which leads to that emotional loneliness. And then we're really working to increase behavioral flexibility, openness, and vulnerable expression of emotion in order to become more socially connected.
And the target hierarchy for DBT has a similar setup. It's just that they're addressing slightly different things within each of those things. I noticed I missed one, so I'm just going to explain that to you guys. But the first one is managing risk for suicide, just like with RO-DBT, but the behaviors look different for suicide. So they're usually more impulsive, more mood dependent. So the behaviors might have a goal to gain attention potentially. And so we're always working first to keep people safe because again, you can't work with a dead client. And so we have to ensure that any behaviors related to suicide, thoughts, behaviors, self-harm, looking stuff up, and just knowing what somebody's risk could be. We have to be taking all of that into account, number one. The second thing on the hierarchy is what I missed, and that is managing, well, not necessarily managing, well, it is managing the therapeutic alliance, but it's not necessarily through ruptures, although ruptures do occur, and we need to address them. And we often do that through repair in a similar way. But we're often looking for things that might make it really difficult to do therapy. So with DBT, that's often not coming, not doing homework, maybe coming but lying, right? Or lying is sort of a broad term, so maybe just not sharing what's happened or saying something that didn't actually happen. And then maybe, refusing to say something to the therapist. So there's so many different things. And it's not only the client that can show these behaviors, right? As Katie was explaining, something could happen that the therapist does, right? And there's often, I remember one time saying to a client that I said, oh, was that just your PTSD, just your trauma? And I really didn't mean it like it didn't matter at all, right? Like, obviously I care about people's trauma. It was more just that I was saying, was it that or that and something else that was bothering that person? And that led to a really big rupture where there was a lot of anger and upset. And so, you know, we ensure that we like watch what we're saying, and we repair. We're not perfect, so if we make a mistake, we say something that upsets somebody, we work on that. Maybe I'm late for a session, right, and that's a therapy interfering behavior on my part. So we watch for all of those types of behaviors. And then the last section on the therapy, the treatment hierarchy, is quality of life interfering behaviors. And so those can incorporate pretty much anything that a client wants to work on. But in general, like, the therapist is sort of focusing on trying to allow this person to gain behavioral control so that they are not engaging in mood dependent responses, meaning, like, if I have a feeling, I do it right away. Like, I'm angry at you, so I throw a plate at you. We're trying to do things like, I'm feeling angry and I'm going to choose whether I throw a plate at you, because it may or may not be effective. Probably not. So then you also are working on encouraging development of strategies to avoid conflict, to organize sort of life and tasks, to restrain impulses and delay gratification.
All right, so now where our skills focus. So RO-DBT doesn't quite have it so beautifully laid out as DBT in these components, but there are 30 skills training classes that cover a lot of different areas. And again, we're working on building up those core skills deficits. But we have a lot of skills focused on increasing openness to new information, or to disconfirming feedback in order to learn. So how do we embrace self-discovery and learning new things and getting it wrong, not needing to be perfect? How do we learn how to activate our social safety when we feel threatened so we can re-engage? How do we enhance our connectedness to others, our ability to be intimate and express our innermost thoughts to the people that we really care about? How do we increase that vulnerable expression of emotion? And how do we improve our ability to flexibly respond to different situations as they come up, instead of responding the same way in all situations, which tends to get us more isolated. So those are our kind of skills focus in RO.
And I'm going to switch to another slide, but it's going to come back to this one. So don't worry, you don't have to. And you're also going to have all these slides. So so in DBT, the skills focus, if I could switch it, the skills focus has like a core of mindfulness. And this is based mostly in sort of Zen mindfulness and kind of the mindfulness that's been brought over to the medical field, so more of a secular mindfulness. So the goal is really to be present, non-judgmentally in the moment. And that is thought to be necessary in order to do any of the other skills. Like, you don't know what you need if you're not present with the moment, what's going on in the moment, yourself and other things, right? And then there are generally, for adults, there are three additional skills modules. So there's skills taught in mindfulness, and then there are three additional ones. This one is sort of a shorter bit, so they repeat. So you keep coming back to teaching mindfulness throughout the skills group in between every other module. And these are usually 6-week long, where we're teaching one set of skills for that amount of time. And this walking the middle path skill is an additional module for teens, and the teens go a little bit quicker, so they usually go about 4 weeks through each of the modules. So distress tolerance is allowing somebody to gain, like the tip skill was one of those, right? Is being able to gain control in those moments where there might be a crisis. The emotions are very high, like 80 out of 100 to 100. And usually this is where behaviors that are really ineffective are happening. So we're using tools to tolerate that intense distress. And then emotion regulation skills are those skills designed to prevent the vulnerability to negative emotion, meaning like it's just allowing you to maybe prevent negative emotion from occurring by doing positive things, by planning for problems, by like taking care of your body and yourself so that you're in a place where you're less vulnerable. And then there's also, that's the sort of preventing negative emotion set of skills, or preventing intense high emotion too, because that can also be problematic. And then there's a set of skills that is about changing emotion regulate, so changing emotions. So being able to calm down difficult emotions that are causing problems for somebody. And we actually try like to do that when emotions are less intense. So they've gone through distress tolerance, and then they start to be able to change emotion and engage more effectively with their environment. And then there are interpersonal effectiveness skills, which teach one to start to get what they need from others, to maintain relationships, like to make them good and feel good, and then also to maintain self-respect in the relationship. So being able to say, this is what's important to me, and I'm just going to stick with that. These are all skills that are really helpful for those going through DBT. And so as you can see here, our goals are really to increase non-judgmental awareness, tolerate distress and manage crisis, prevent vulnerability to emotion and change difficult emotions, and then learn those interpersonal skills. And then for adolescents, that walking the middle path module it allows this some really great ideas in there in order to think dialectically, especially in a caregiver-child relationship.
All right, so the differences between client presentation for RO-DBT versus DBT. So RO-DBT was developed for more internalizing problems that are associated with disorders of over-control. More often, this is a better fit for individuals who have either a cluster A or cluster C personality disorder diagnosis, so avoidant, obsessive-compulsive, paranoid, schizoid, PD. Um, so chronic depression is really effectively treated by RO-DBT if at the core of that chronic depression is this more over-controlled biotemperamental predisposition, which is seen in quite a few chronic depressed clients. Similarly, treatment-resistant anxiety, autism spectrum disorder, and anorexia nervosa, so that primarily restricting controlled eating disorder. Then, although they both have high rates of suicidal thoughts and self-harm behaviors, for over-controlled individuals, when they present, their suicidal thoughts and self-harm behaviors are usually planned, usually a well-kept secret, and they're more likely to be rule-governed. So some individuals will talk about it as a form, much more a focus of a form of self-punishment or righting wrongs that they've done that maybe nobody knows about because they're really good at suppressing and hiding. And sometimes it's very based in reality, right? There's some things that they have gotten away with that they hold a lot of shame around. And sometimes they're more their perception of it is a little bit more intense on themselves, and they hold a lot of excess guilt than what would make sense. So those are some kind of like the differences in what you would be looking for, especially diagnoses or kind of the source of the problem that they're coming in with. That would be a better fit for RO-DBT.
And for DBT, as we've mentioned before, these are more, you would see more externalizing problems, more that are showing up in, all areas of life, home, school, work. And then cluster B personality disorders are more likely to need DBT. And problems linked to difficulties with self-control, so substance use, conduct disorders, bulimia, binge eating. And then suicide and self-harm behavior, as mentioned before, is relatively, it doesn't mean that sometimes people don't have plans, like there is that overlap, right? Of course. But it's usually a lot more likely to be impulsive and mood dependent, and also meaning that like maybe in one moment there's a desire to kill themselves and then that goes away later. And then that there's the self-harm behavior is often it can have a function of punishment, but it's more likely, again, impulsive, mood dependent, and then also more likely to have a function of sort of attention seeking or showing somebody that there's a problem. And then also of just trying to regulate the pain and get it to go away, to feel pain that's physical in an intense moment. And so you'll have these slides, you can see we've kind of reviewed these, but these are the typical, it's just a way to kind of look at the under control disorders and the over control disorders that might be appropriate for each treatment. And so we'll just quickly review assessment measures because they can give us a sense of overall, like obviously when we're doing a diagnosis, it's good to have a sense of sort of the overall picture, but also if we get some specific measures, we can get some additional clues to some of the core issues that are underlying problems and maybe direct us to one therapy or another. And so we can kind of better understand the clinical picture. So we'll just review some measures that we typically use in each when assessing for each. Now, of course, somebody's coming probably to me, for example, they're usually coming for DBT, right? And so we're assessing for that. And then, and I think similarly, although I don't know, Katie, you have to speak to that for yourself. But for DBT, we have, like any other time when we're trying to do therapy, we're doing a comprehensive intake. There's some really great, these are all assessment measures that are taken from the University of Washington, what they do in their intake. They have a lot of different questionnaires to get a sense of social history, demographics, a lot of like psychiatric history. It's really, really helpful. And in addition, we usually use the borderline, or we always use the borderline symptom list, gives us a sense of the symptoms of borderline. We also do DBT ways of coping scale, which gives us a sense of how much somebody's using scale, like how well are they coping so far when they're coming into DBT, like what areas might they be struggling in. And then a reasons for living scale, which gives us a good information about how to kind of help somebody stay safe and what matters to a person. And then we just get some other symptom measures. Typically, we do the patient health questionnaire to get a sense of depression and suicidal thinking. And then we also use a suicide attempt self-injury interview if there's any self-harm. And that gives us a really detailed understanding of self-harm, the functions of it, when it's happening, what's happened. And then the Linehan risk assessment and management protocol is the risk assessment that's typically used in DBT. And we use that as well to assess for suicide risk and what has happened in relatedly, what has happened in the past.
All right, and these are the RO assessment measures. There's a very set step-by-step protocol for assessing for over control that you learn through the RO-DBT training. And so in addition to some of those general clinical interviews where you're identifying diagnoses, you're also giving a specific self-report measures, which are the first two styles of coping word pairs. That's a self-report where clients kind of self-identify more as OC or over-controlled or under-controlled. And then there's an OC trait rating scale, which is a self-report measure, how well the client perceives that they kind of match some of these OC traits. And then there's two clinician-rated scales to see from the clinician perspective how well the client matches with OC traits and OC prototypes. And those are available when you buy the RO-DBT textbook. And we'll provide some other resources. There are other additional RO-DBT assessment measures by other authors. So if you've seen any of these, there are specific parts of different assessment measures that are shown to correlate to a more over-controlled presentation, which is great. So Definitely check these out. I want to make sure that we have time to get to our case presentation, so you guys have time to practice some of what you've learned. But these will all be available in the slides. Great assessment measures to check out and give if you're thinking somebody on my caseload feels pretty over controlled, and I want to give them some assessment measures to get some objective data.
Okay. So we're going to do a case example. I'll just read through the case we're presenting, and then what we would like is for people to send questions in the chat as if they were assessing. So maybe just one question per person, so we can kind of, or just one question at a time. So Katie can kind of watch those as they come in, and she can ask them to me, and I will answer them to give you a bit more understanding of what this patient looks like in the, let's say you're assessing them. And then we'll do a poll after to decide which therapy you think this person needs. And so just be thinking throughout, like, about all the things we've talked about, what might be, the most appropriate therapy. Okay. So our client is a 30-year-old heterosexual cisgender female. She was born in Utah and values her Middle Eastern heritage. She's a practicing Muslim. She's divorced, has one child, and works full-time as a lawyer. She's seeking treatment to address ongoing and increasing social anxiety and worsening procrastination behaviors at work. She reported a history of disordered eating, though denies any current behaviors. She endorsed current suicidal ideation and self-harm behaviors. Okay, so ask away. What else do you need to know? Or do you guys already know? It's like, so this person could go either
Yeah,
way.
so put your questions in the chat. Okay, amazing. We've got some questions. Sweet. All right. From Sheila, does she self-harm impulsively? So what is her self-harming like?
She self-harms when she gets difficult feelings. I like that question. I just want to get more questions. Good one.
We're
I'll
gonna
answer
encourage more questions. Does she have a suicidal, does she have a plan of how she would commit suicide? And does she feel like the thoughts are more intrusive or more deliberately considered?
Good questions. Yeah, she has a plan. Again, I'm going to leave the rest and tell you more and answer that in a minute. She does have a
She does have a plan. What is the nature of her disordered eating? What kind of disordered eating history does she have?
Yeah, she has a history of restricting her eating when she has high stress levels. She's worked on her relationship with food in her 20s, and now she doesn't really restrict very much anymore.
Has she tried other therapy approaches?
Yes, she's tried a lot of therapy. She's been through 3 therapists.
What's her social life like? Does she have any close friends?
She feels like she doesn't have a lot of support and that she struggles in relationships. She really doesn't think people like her.
Is her procrastination behavior impacting her performance at work, or is it something that causes her to work very hard as a deadline comes up? So only she knows how bad her procrastination is.
Yes. So she is having a hard time at work. She feels like she doesn't get enough work done. And she, yeah, to answer that specifically, because now we're getting into, I'm going to answer all the questions, unless there's another type of question. Is there a different type? Because I'm going to go into more detail.
There's more of those in-depth questions about the nature of her suicidal thoughts and self-harm
Okay.
and some other procrastination questions.
Okay. So she feels like she's behind at work, but she always gets stuff done on time and her performance evaluations are good. To answer a little bit more about self-harm and suicide, she plans, nobody knows about her self-harm. She cuts herself on her stomach, but never deep enough to need stitches. She always cleans a blade. She has bandages and Neosporin to clean it up, make sure she doesn't get infected. She plans to kill herself when her daughter is old enough to not need her anymore. Any other questions? She likes to skydive and take risks.
What kind of questions would some of you guys ask when someone has behavior like that? New onset of skydiving. So there's some questions about what about skydiving is fulfilling for her. What does she aim to get out of it? The why behind why she's taking
Yeah.
that as a hobby.
She really likes that feeling of just being like free. And so she just goes, she makes sure to plan that as often as she can. Is there anyone that I didn't answer fully to go back to?
Yeah, if there were any questions that we didn't answer, maybe we missed.
Oh, relationships too. Like specifically, what about relationships might you want to know? Because she has a hard time.
Yeah. So relationships, and then also, is that the only area in her life that she lets go in? So are there other kind of similar to skydiving type behaviors? Or past aversive life experiences?
Do the poll, I guess.
You want to do the poll? You want? Okay. Yeah, we can do the poll.
We can keep going. Questions. We have a few minutes left.
Yeah. I mean, I guess the question is that the only area in her life that she lets go in was the first one to follow up.
Sorry. No, sorry. Yes, she really struggles to let go in any other area and really feels only comfortable doing it like when she's planned it and just going by herself with her instructor.
And does she have any past adverse life experiences?
Oh, sorry, I didn't realize this was a question. Yes, she has some past trauma and she has a sexual assault in her history, and she also had a very difficult relationship with her ex-husband, and so that divorce was very difficult and emotional.
And then more questions about her social relationships. Can she make and maintain friends easily, or does she struggle with this?
She really struggles with that. It's really hard for her to connect with others. If she's around other people, she often feels alone.
All right. Let's
Ready?
roll this.
Ready for a poll?
Yeah.
Okay. Do you want to do it? Are you doing it?
I can do it. Yes.
All right. Let's see. How much have you guys learned? Which
All right.
therapy modality would this client benefit from? So far, we have RO-DBT. Okay.
All right.
Anyone for DBT?
She skydives.
Yeah.
Okay.
No, but
Ending.
those questions were really effective. I think really effective ways to kind of understand which client. It's sometimes pretty complicated to figure out which may be more appropriate. Okay. Wrap this up, Katie.
All right. Are there the next slide?
Oh, sorry.
Just to talk, I guess, but this question, skydiving is her attempt to therapize and lose control. So actually a lot of my over controlled clients have what you could consider as like high risk and maybe even think are impulsive behaviors. But the differentiator between these, my clients that like do really, really intense and scary rock climbs, skydive frequently, do really deep sea diving, that can be really dangerous. It's all planned and calculated risk. Yes, it's not impulsive. This is like, I'm learning everything. I'm putting myself in these situations to kind of experience that feeling. And yeah. All
Um,
right. Um,
Can we take 1 minute to just go over a couple of questions I noticed? And
yeah,
then
definitely.
so very early on, someone was saying, looks like those in under control often get stuck in emotion mind. And was asking, would you say that those with over control, maybe you answered that one, Katie, did you?
I did
Okay.
answer that in the chat.
Okay.
Yeah.
Yeah. So that's a good one. That you might also understand that in under control, people are often switching back and forth from that sort of logical mind to the emotion mind. But yeah. And then that PTSD can be a really core piece of this where you might see people going sort of to either RO-DBT or DBT. Okay.
Yep. And then we had 3 questions that got submitted ahead of time that I just wanted to touch on. So thank you guys for submitting those ahead of time. One question was around resources to further your education in DBT and better use it in practice. And we are going to include links to both of the major websites where you get trained in both DBT and RODBT. So those will be linked here, but one is Radically Open and the other Radically Open is for Radically Open DBT, and then Behavioral Tech is the website for DBT. We got a question if RODBT is good for people with OCD and borderline personality disorder. And then the question was, are there differences so profound that they require different modalities, or do they overlap in some way for these patients? And my initial, right, this is just my from my clinical training and where I'm at, I would likely think that RODBT would not be the best fit for an individual with a borderline personality disorder diagnosis. Because at the core of that diagnosis is that difficulty with self-control, that under-controlled temperament. That would be a better fit for traditional DBT. And then potentially doing ERP, depending on how severe the OCD is, with stage 1 or primarily in stage 2 DBT. But Jessica, please feel free to share your perspective on that.
I would
Whereas,
just say, Oh,
Yeah,
sorry.
go for
I would
it.
just clarify that stage one is what we were referring to today. It's like a year of treatment where you're working through the behavioral regulation and safety and stability. And then stage two is where you could do things like ERP and treat OCD typically.
But if the individual had a diagnosis of obsessive compulsive personality disorder, then they would be a much better fit for RO-DBT. And then the last question we received is if there are trainings available for international grad students, either online or in presence. And so, in person. For RO-DBT, all of the levels of training are available in blended learning. So that allows people from all over to access that training. And then they do level 3 trainings. They have some upcoming in the US. I think there's one in Georgia happening. And then Australia and the UK are the ones that I see that are planned. But outside of those, I don't know if any other in-person trainings in other countries.
Yeah, and DBT is similar where, so essentially with DBT, you need to connect yourself with a team. If you want to do a program of, if you want to learn how to do a program of DBT, you need to connect yourself with someone who's involved with a team of therapists doing DBT. And then you can do training through behavioral tech to do what's called foundational if you're just doing it by yourself, or intensive if you're doing it with a team. And there's similar material, but it just gives you a lot of background. It's usually like in person, it's a 4-day training, which are run throughout. I think they're also all over the world. I know there are quite a few in the States, but it's also run online through PsychWire, so you can do the program online. You just need to connect with somebody who has a team, and who can supervise you.
Mm-hmm. All right. And then for all of you guys, I hope that this encouraged you to get trained in one or both therapies, and also will help clarify for some of your clients really which ones you feel like is a better fit. If you do not have the bandwidth or the urge to get trained, especially in RO-DBT, feel free to refer those clients over to UC-EBT. We're really developing a program for it. We have active skills classes going on. I would love to start another one. And so I am accepting outside referrals, even if it's just for skills class right now. So that's been really fun. So, or for consultation, if you want to consult about RO-DBT, please, happy to talk about it.
Yes, always happy to talk about DBT, consult, and also take UCBT. You can take referrals for DBT as well, right?
Yeah.
Thank you.